Okay. Yeah, why don't I go ahead and get started? I can introduce myself. My name is Eric Mendonca. I help lead the equine commercial team at Flexergy. Also help a little bit on the technical side as well in terms of the product development. In terms of Flexergy, we've been around for a little while, and our goal is to increase the accessibility to testing, to results that are critical in improving the workflow of the veterinarian. And for us, education is critical, and it's really been something that we want to continue to invest in, and improving kind of our knowledge base of diagnostic methods, diagnostic techniques, whether that applies to kind of near patient testing, or even just understanding the current standard. I think our two presenters today don't need too much introduction. We're really happy to have Dr. Ben Sykes and Dr. Nicola Pusterla to support on our scientific advisory board, and also help improve the education and support that we have for our partners. In terms of just how today will go, I think we have 6 sections that we'll go through in terms of the content. Please go ahead and add any of your questions to the Q&A. We'll try to get to them within each section, but then additionally, if we're not able to, we'll try to cover them at the end, or there'll be great ideas for a follow-up session. So with that, I will pass the ball off to you, Dr. P. And thanks again for joining us today.
Yeah, thanks, Eric. Thanks, everybody, for joining today. Hey, Eric, would you mind moving the slide? I have little control here. Thank you. As Eric said, we have a lot to discuss here. We'll look at Salmonella, what it really means, biology, different testing platforms, the whole concept of pooling, number of samples to use. So there's a lot of material that we would like to cover, and we'll hope we'll do justice to it. Before we start, the way we're going to do it, we're just going to switch topics between Dr. Sykes and myself. Before we start, I got the easy part of the definition. If you don't mind moving to the next slide, Eric. Well, we recognize salmonellosis of a clinical entity. We'll see in either acute or chronic, of course, with enterocolitis, or falls with sepsis. We have to recognize that most of the salmonella shed in the environment are actually coming from horses that are colonized without showing clinical signs. So this is what we call subclinical infection. And we'll be talking a lot about subclinical infection. And I think it's essential, why we look at clinical salmonellosis as one of the key diseases to potentially cause nosocomial infection. We need to recognize that it's actually subclinical infection that silently spread in a hospital setting, equestrian facility, and potentially then gets passed to other horses. So very important to keep these two definitions in mind. And with this, I'll pass it to Dr. Sykes, who is going to start with the first topic.
Yeah, thanks, Nick, and thanks everyone for joining us. So I think that's a really great entry into why this is relevant. So, why is testing for Salmonella relevant? And when we think about it from a hospital and a clinic point of view, we've got economic risks, we've got legal risks, and we've all heard the stories of the outbreaks and how much that goes. I think we have a really high ethical obligation to our patients, and it's not just our patients that are sick, it's our hospital patients and it's our environment. And I think there's an ethical and legal intersection there. It's really hard to defend, to say we didn't see this coming, we didn't know about this as a risk. And so understanding that and managing that risk is really important. We're going to talk about risk a bit more. One of the things I think COVID's taught us is risk is not dichotomous. It's not there or not there. It's a scale. And so that's what we're going to spend a little bit of time talking about today. There's that risk to ourselves. There's that risk to staff. There's that risk to owners. Knowing a patient has Salmonella might change what we do with that particular horse. So, I take the example of a horse in the clinic that's maybe got diarrhea, and fecal transformations become really popular. And so we're going to nasogastric tube and fecal transfonate that horse. Whether it's effective or not is a story for another day. but we might be a little less excited to do that if we know that that horse has Salmonella, versus if we think maybe the horse is Salmonella negative and Clostridia, which is maybe more of an indication for that. So when we think about our invasive procedures, and when we think about even things like rectal exams and stuff like that, what happens with the material after we do that? So understanding that risk and that zoonotic risk, understanding that risk not just to ourselves, but to a broader population of people, pregnant, immunocompromised, and all these different things. In terms of patients' care, understanding our biosecurity risks and determining our biosecurity requirements. And there's no one size fits all for biosecurity, but building it so that we understand the biosecurity requirements for our patient. And then using that diagnosis to guide treatment. It's debatable whether we would use specific diagnosis of Salmonella to, say, guide antimicrobial therapy in an adult horse. But if that animal's particularly leukopenic and we're worried about septicemia, or if we're dealing with a foal, get an early and accurate diagnosis of Salmonella in that individual patients can be very important. It also works the other way. If we can rule out Salmonella confidently and we start thinking about other differentials, that's going to impact our treatment as well. So when we think about this, who's got Salmonella in our populations? And so our isolation patients, these are the ones that everyone worries about. Everyone worries about the isolation patients. And there's about, depending on which data you look at, 5 to 15% of those horses will have Salmonella. I'll segue briefly and say, for a disease that's so important, we actually have a very, very little knowledge about beyond that, about what happens in the rest of the world and the rest of the populations. We know that colic patients or patients with non-colitis GI disease, that's between 3.5% and 13%, so not dissimilar from our isolation patients. But if we just look at our general population, our eight patients, we've got some data. We're working with one of our clinics. They're detecting between 2 and 3% of their outpatients are shedding Salmonella. And there was a study about 20 years ago that looked at it was a USDA study, looked at the general population, and they found 0.8% on a single culture. If we translate that to actually the real prevalence of disease, that's about 1 to 2%. So it's a really, really common to see these horses in the population. The critical thing here is it's not the isolation patients that get us. The isolation patients are locked up in Fort Knox. They've got all the bells and whistles around them, and it's very, very rare that we see an outbreak from an isolation patient. It's these other horses in our population, and it's the environment. And so we really worry about these silent shedders and the horses that we don't see and we don't perceive as risk. If you go to the next slide, please. And here's a really good example of that. So this goes back about 15 years now. This was the outbreak at New Bolton Centre. And basically the outbreak at New Bolton Centre, when they looked back, they said, we were watching these isolation horses very closely, but that's not what got us. This outbreak was a $4 million outbreak, very high profile. It was the routine patient surveillance or the absence of routine patient surveillance that got them. Next slide, please. And so if we look at a contrast that came out at almost, sorry, go back one. If we look at a contrasting study that came out at almost exactly the same time, which was Colorado State, who were ahead of the curve, they said we had aggressive surveillance, not just of our colitis patients, but of our general population. And when we see a problem, we're able to intervene. So these two studies to me really demonstrate the value, the importance of those non-colitis patients and the value of monitoring those non-colitis patients.
Do we have any questions for Dr. Sykes on the relevance of Salmonella? Not yet. People have to warm up. So I'll be interested. We always talk about ethical and legal implication, and knock on wood. I think we're doing a relatively good job in our hospital, and generally people don't get too upset when horse acquires and there's a common infection. From a biosecurity standpoint, and you have worked private practice in academia, what do you feel would be good standard of care in regard to biosecurity for hospital? And I know these are just guidelines. Everybody has a different opinion on this one.
Yeah, and I'll answer that, I guess, with a negative. I think it's not acceptable to say we don't have a problem, to put our head in the sand and say we've never had a problem, we don't have a problem. I think we have enough evidence to say that, it's not if, it's when we look at populations. And so what that actually means in practice is going to vary from place to place. I think that the minimum standard is one that has demonstrated a thought process, an understanding of the risk, and then appropriate interventions on that risk. And so we all do it for colitis. To me, barrier precautions and monitoring those colic patients is really important. And then where we come into those routine patients and how we manage those routine patients. And critically, it's not going to be one size fit all, but I think from a legal point of view and an ethical point of view, the most important thing is that we go through that process and we do an appropriate risk assessment to our own environment.
That's pretty good. So I'm gonna take over here on the choice of biological sample, and really the goal with any organ system that is affected, and we're talking GI tract here, is to find the appropriate biological sample that gets us hopefully to an etiology if we get presented with a horse with fever, leukopenia, and diarrhea, but also having a adequate biological sample that allows us to screen horses that come to the hospital. If you're looking at routine surveillance. So any biological sample that we can collect throughout the gastrointestinal tract will be a fair game. However, we need to truly understand that there is little information, there's little data out there when it comes to comparison. So if you look at the common biological sample that are collected, feces is the most common one. There's no doubt about that. And I would say the second one, probably the rectal-anal swab. And then after that, occasionally we'll have, people trying gastric reflux, and I'll talk a little bit about mucosal biopsy. If I may ask Eric to move to the next slide. So as I mentioned before, feces, and it doesn't really matter if these are grabbed feces off the ground from a fresh pile or feces collected from the rectum, these, in my opinion, are, the best biological sample. The warmer, the better. It'll allow you to assess or support, clinical disease, and also cover other enteric organism, but it's also the sample of choice when we're looking at subclinical cheddar. There is little information out there that, compare rectal-anal swab with feces. And you always have to ask yourself if feces is generally easier to collect, there'll be indication where a rectal swab, probably the other option, when there isn't enough fecal material around, when, let's say, it's difficult to capture some of these very watery diarrhea that really seeps through the shavings, then a rectal swab may be more indicated. If you're dealing with foals, generally that biological sample is taken. It's, in my opinion, an acceptable sample. However, what we need to take into account is when it comes to the diagnosis and either the culture in a PCR, one of the relevant aspects is quantity of that matter, of that organic material. With feces, you have a lot of fecal material. With a rectal swab, you just have whatever fecal material and fluid that has been present in the rectum that accumulates on the rectal swab. So definitely less. So if you have a choice between the two, I would go feces before you go rectal swab, but still a good alternative sample. Reflux, it's an interesting one. Every time you see a horse with, gastric dilation or potential ileus, we like to collect reflux, and we'll test the reflux for other enteric organisms, mainly clostridial organisms. It is worthwhile considering testing for Salmonella. However, if you do that, I would also consider to test other biological samples, so test feces. And then we can debate about, well, should we pool the two together? Should we test them separately? The more sample we collect out of the same animal, the more likely we'll rule in or rule out Salmonella. Probably the best biological sample that you can collect would be a mucosal biopsy. And all these, all the little study, all the little information is available, has been looked at via culture. But we know that via culture, mucosal biopsy are more frequently positive than feces out of the same animal. So greater sensitivity of mucosal biopsy. Now, while the sample may appear to be better, unfortunately, there's an issue with the collection of these biological samples, especially when you're looking at, collecting multiple samples from the same animal to rule in or rule out Salmonella. I think mucosal biopsy is probably not an option, but still an option if you have an equivocal case and you want to look at a biological sample with greater sensitivity. Again, what I just want to emphasize here is that all the studies that have been done the few studies have been done relate to culture. We really don't know how these biological samples compare against each other when it comes to PCR. We have a very quiet audience here, no questions.
And so do you think, so we say, you know, we've held that, and I like the idea, and we keep saying the very little information available. And I sort of said before, like for something that's such a common, important disease, when you really dig into it, the paucity of information is quite staggering to make these decisions. And everyone would like a nice, you know, black and white answer, but it's really interpretation. Do you think, we say rectal mucosal biopsy on culture, do you think that still applies when we get to PCR? Or do you think the higher sensitivity of PCR starts to remove that potential advantage?
You know, that's a good question. And I wish I would have the data. I mean, there's no doubt that the sensitivity issue relates to sample type, culture, definitely. And I would say it will be taken over with PCR as well. Despite the fact that PCR has a greater sensitivity, I would say mucosal biopsy will probably perform better than feces, and feces will probably perform better than a rectal swab. Remember, it's a matter of quantity. And we know that the more fecal material we have, doesn't really matter if it's out of a swab or, you know, biopsy or feces, the better the outcome will be.
And so the other question that flows from this, and we're going to talk about pooling a little bit later, but is the role of enrichment. And I guess if you could expand on the role of enrichment, and particularly the timeline. You know, we have these timelines. What happens if we go too soon? What happens if we go too late?
Yeah.
What are the implications of being outside these recommended enrichment timelines?
Yes, and so the enrichment is essential, is really essential, especially when you deal with enteric organisms. Remember, when you look at fecal material, it's not just Salmonella or no Salmonella, is a bunch load of enteric organism, which means that Salmonella generally, if present, is present in small numbers. So the whole concept of a selective enrichment step is to allow small number of Salmonella to grow to the point where they can be detected, but also prevent other enteric organisms from expanding too much. And that's generally the issue that we have. It's going to be impossible using culture to then define, you know, are there sporadic colonies of Salmonella if you don't have a selective enrichment step. The other aspect is time dependent, and there's various studies that have looked at time. So if you look at how much time is essential or how much time is needed to undergo that enrichment step, you know, we say 20 to 24 hours. It also depends on the initial load of Salmonella in that sample that was inoculated in that enrichment broth, but it also depends on the recovery. You know, some of these organisms may be stunted, present in small numbers, so it's going to take a time to recover. I always say, you know, if you're in a rush, you can test the sample anywhere from the time you collect it and you put it in the selenite broth or any other enrichment broth to 20 to 24 hours. So you're allowed to collect right away, to collect at 12 hours or 20 hours. I would caution people to extend the time over 24 hours, mostly because while it's selective, other enteric organisms will grow. It's going to make the interpretation more difficult. The more microbial organism we have, the harder it is to differentiate them on a culture plate, but the more likely we'll also have inhibition in a, you know, PCR setting. You know, to answer your question, when we look at direct fecal analysis, either through culture or PCR, and then the same sample 20 to 24 hours later, we will capture a higher number of Salmonella positive cases post-enrichment. So that's the whole idea of the enrichment, because Salmonella is shed in small number generally and intermittently. You're better off, or you're almost, you know, forced to, you know, undergo that selection step in order to accurately define that that sample contain or does not contain Salmonella. If you decide to, if you have a sample, let's say if you have a sample and it's 24 hours, maybe it's the evening, you're not going to run the PCR test until the next morning. What I always recommend people is after 24 hours, take the sample, put it in the fridge. Nothing is going to happen. It's going to be a status quo. Or you can freeze it. If you do PCR, you can freeze it. It doesn't really matter. But you keep it at 4 degrees in the fridge. There won't be any expansion, any growth, and you can test the sample later on. But I would not give that sample more time just because of convenience, or expect that, longer periods of incubation will get you better result. That's definitely not the case. It's very important to stick around that, 20 to 24 hours.
That's really interesting. And I guess we can test early if we're anxious or we want that information. We can test early, and if we get a positive's a positive. Correct. And if we get a negative, we want to go back and test within that ideal window.
Correct.
Yeah, excellent. Next slide, please, Eric.
I'm going to keep you guys on track here. We do have a couple questions coming in, but I think they correspond to pooling and environmental testing, which I know we'll get to a little bit later. But I will keep you guys on track in terms of getting to the next topic.
So then we switch and we start talking about the accuracy of the different techniques, culture and PCR. And, we've put the term sensitivity and specificity here because that's what we use, but we were actually having the conversation about this last week, and it's not really, we don't have a gold standard. So this is probably, its detection rate is probably the best that we can say. And what we know is that, sensitivity detection rate for culture is fairly low. For a single culture, it's sort of that 25 to 50% range. So we will look at the interpretation of that in a second, but we can certainly we can miss a lot. Sensitivity is, if the disease is there, what's the likelihood we're going to find that? We all know that it's magic. We've all taught 5 cultures, and that brings us up, if we're at 50% for an individual sample, that brings us up to 98% sensitivity. But if we're down at that lower end, it's still only 80% sensitivity. That's not a very good test. We generally want our tests performing in the 90% sensitivity specificity. So culture's been so embedded, I think largely because we haven't had a better tool for a long time. And then we start to get a better tool in PCR, and it's then how we can use that most effectively. In terms of specificity, i.e. if you're negative, you're going to get a negative result. We say that culture's 100%, i.e. if Salmonella is not there, it won't grow. But that's only true if we actually accurately identify the organism that we're growing. So if we identify on the basis of, say, a black colony, we have other species of bacteria that can cause black colonies, and we'll get a false positive. So to say that culture is 100% specific means that we have to be doing it through to the identification stage. Next slide, please. If we look at PCR, there's a range of data on PCR. Most of it's fairly old, but it still sort of flows through. And we see our sensitivity starting to push up closer to that 100% mark, which is, if the disease is present, we're going to find it. Now, we know that horses are intermittent shedders, so we still need to test multiple times, but if it's present in that sample, it's highly likely we're going to find it with PCR. And specificity with PCR is very high as well, and so it gives us the best of both worlds. If, we always talk about PCR potentially being too sensitive, and it'll pick up the tiniest fragment, but this goes back to the conversation about enrichment. The whole point of enrichment is it's growing something that's live and viable. So if we're detecting it after enrichment, then it's something that's live and viable, and it's probably real. Next slide, please. So when we think about that in terms of how we interpret that, when we think about culture has a relatively low sensitivity unless we're going out doing our 5 cultures. And even then, that may not be enough. If we're at the lower end of that sensitivity range, we're going to get false negatives with low sensitivity. Now that makes us feel good because we tested the animal and tested negative, but it's a false sense of security, and that's going to give us missed cases, and that's going to give us, in terms of our risk element, the one that sneaks through, the one that bites us that we didn't see coming. We say that culture is highly specific and we shouldn't get false positives, and the advantage of that is if we don't get a false positive, we're not going to unnecessarily impose biosecurity on a patient. But again, it's really important to recognize that's only true if we go all the way through to identification. One more click, please, Eric. When we think about PCR, our higher sensitivity means we're going to get a far few false negatives. We're going to have a greater true sense of security rather than this potential false sense of security. And that's going to flow through to better decision making for our patients, facility, and staff. And our specificity is still very high, so we have very few false positives. So, you know, PCR, in terms of PCR versus culture, we're going to get more positives, but those positives are real, they're important, and they're relevant to what we do. Any questions on that?
So we do have one question from the audience, Dr. Agnew, and you may cover it a bit later, but I think it's you touched on it a bit.
Yeah,
But
Eric, hold on. I think we're gonna touch on that question on the next section,
Okay.
and Dr. Perry's question as well down the road. So bear with us.
We'll get there.
We'll get there. I have a question for you, Ben, because I get that, you know, I'm a fan of PCR, but I have to give culture, I have to do justice to culture, all right? So it's not PCR, no culture, or culture, no PCR. Is, in my opinion, culture with, PCR with indication to culture. So, and I have my own little opinion here, but in your experience, what are indications? So let's say you screen PCR, you screen by PCR, hospital setting. Would there be indication once you get a positive one to say, hey, I gotta go back. I have to take that cell and I have to move it. I have to send it to micro, and I have to figure out what it is: Salmonella, serotype, serovar, and so on. What are the indications, in your opinion, that are still worthwhile considering?
I love that phrase. I love that phrase, screen to culture. So using that PCR positive as a trigger to say, now I need to culture, rather than saying they run parallel, you know, it's a sequential step. There is value in culture, and it's not gone the way of the dinosaur. Like, it's not completely redundant. It's going to give us really important information at an individual patient level. If we have that antibiogram, we know if we do have a complication, or it's a fall, or we do make that decision to treat with systemic antimicrobials, it is going to give us the right information to operate appropriately and use the right choice there. It's also going to give us really important, and this is true of all culture, not just Salmonella culture. This is something we probably don't do enough of, that historical knowledge and database about what's going on in our population and what's going on in our hospital. So, you know, at the simplest level, if we see the same organism with the same antibiogram 2 or 3 times, we're going to be asking some very serious questions about where that's coming from, i.e., is it coming from our facility? And we know there's data out there that says that, you know, that we always, you know, how long does it take before they can be a nosocomial infection? It's a very, very short window. It's a few hours. And so we might collect that sample at 6 hours and go, oh, it's positive, it must have come in with it. But we see the same one in the next patient, and it's the same serovar, it's the same antibiogram. We're going to start asking questions about where they're actually getting this from. So I do think there's real value in understanding our population, as well as the value to that individual patient.
I'll just ask you one question before I move to the next topic. How do you answer if somebody says, well, you know, PCR only detects genomic DNA, so it doesn't mean that the organism is viable. Hence, why should we worry about it? How would you answer that one?
Well, I think we go back to, you know, that's why we do an enrichment. We know that if we do PCR without enrichment, it has very low sensitivity. We very rarely detect anything if we just take the sample and PCR it. The fact that it's growing during enrichment tells us it's viable. It's a biologically viable. It's not just a genetic fragment. It is a biologically viable organism. So that, to me, is the answer. If we were doing PCR and just getting fragments off a non-enriched sample, I could maybe buy that. But the sheer fact that enrichment is an absolutely necessary step, and enrichment will only grow a viable organism, I think negates that argument personally.
I will agree with you. Thank you. That's very good. Okay. Eric, may I ask you to move to the next slide? Okay. I'm going to talk a little bit about pooling, and I think that's going to hopefully cover Gustavo's question on pooling. If you think about testing a Salmonella, we're chasing negative results. Am I right? So we're spending time and we're spending countless money on, if I look at our hospital, you know, 1.2 to 1.5% positive results. Hence, if you consider pooling as a strategy, and that may be true for culture as it may be true for PCR, it has the benefit, I mean, many benefit, which is, saves money, saves time, saves resources. That said, it does not apply to every single case. So if I see, if I see 2 or 3 cases coming in with enterocolitis, I'm not going to pool these cases. I'm not going to pool sample from horses with clinical entity. However, where pooling may be of benefit, and there's some data out there, is into screening patients. So if you're looking at, if you have, let's say, in a hospital setting and you have routine monitoring and you decide to, screen every single horse that gets hospitalized on a daily basis, you could consider screening and pooling sample from your, so in quote, healthy, non-GI diseased patients. They're still high-risk patient, low high-risk patient, but still worthwhile considering. The other part is these horses that, test positive and potentially have to go home, and the client, needs to follow up with like 5 fecal sample taken 12 to 24 hours apart at different interval, in order to figure out that the horse is or isn't shedding. We know that we can keep biological sample, such as feces, without impacting sensitivity in the fridge up to 6 days. So here's a strategy. We say, hey, collect a fecal sample, fecal ball once a day for 5 days in a row, and then pool the sample together. And another area where I think screening and pooling would work very well, and we have actually data, I'm going to share that data on the next slide, is environmental sample. When you're looking at elective sampling, where, hospital setting, you sample once a week, and how many samples you have, you potentially should consider pooling in order to save money as well as resources. Eric, may I ask you to move to the next slide? There's actually 2 studies that I think are very compelling to support pooling. One looked at culture, where they took feces and spiked the feces with Salmonella different concentration, and they found that if you take up to 5 fecal sample and you have 1 list pool with Salmonella, you will not impact the sensitivity. However, there is 2 caveats to that. One is that it is depending on the amount of fecal material that is used, meaning that it takes a minimum of 10 grams in order to reach a good sensitivity, which is a little bit questionable when we think and consider that, when we're doing PCR these days, we are short of, probably 1 to 2 grams. That's all we're taking. But again, we're dealing with a technique that has high sensitivity. The other aspect with the first study, which I think is very important, is the fact that Salmonella, if you think about Salmonella in the feces, it's not randomly distributed. There are clusters, which means that in order to open the clusters and hopefully being able to have organism present in a biological sample, it is worthwhile considering homogenizing the sample. So what does that mean today would be, take 10 grams of feces, mix them, let's say, with PBS, homogenize it, vortex it, and then take an aliquot of that homogenized sample in order to inoculate an enrichment broth. The other pooling study that came out of our study group looked at the pooling of fecal and environmental sample, up to 10 sample. However, the strategy here was not to pool the sample and then go into enrichment. The strategy was to enrich every single individual sample and then to pool individual aliquot of the selective broth to then go into PCR. The whole strategy there is that if the pool is positive, you got to be able to go back to that original enriched sample and screen each of these 10 samples to say, hey, it's number 3 out of that pool that is positive. If you pull the sample at the beginning, there is no way to go back. You have to collect additional sample. So when we looked at this study, we found that the pooling up to 10 fecal pool of enriched selenite or enriched environmental sample gave us results that were as sensitive as culture, which means that every individual culture that was positive was picked up in one of the pool. When we looked at individual PCR and compared to the pool, we were able to capture a little bit more than 80% of PCR positive individual sample. So again, as good as culture, pools up to 10, as good as culture, but not as good as individual PCR analysis. That said, if we look at the positive outcome, we were able to reduce the cost up to 80%. So we were 4 times less expensive by pooling the sample compared to individual sample. And we also be able to reduce the hands-on on these, approximately 60%. But again, you have to consider that depending on where you practice, if the general frequency of a positive culture, fecal culture or environmental culture is low, pooling is definitely a very attractive strategy in order to reduce cost as well as hands-on and time of your personnel. So any questions on this topic?
I was just going to make a comment to reinforce that. I mean, I feel very spoiled that I get to have all this one-on-one time with Dr. Pusterla, because there's all these great insights. And one of the ones that I had never thought about was the vast majority of what we're doing is testing for negative. And so that ability to mass test negative and then go back and pick out if we get a positive, which is a relatively rare event in these situations, was sort of a real epiphany for me, going, that just makes perfect sense. It's such a simple, logical thing to do. My question relates to, we talked about pooling, and you talked about pooling post-enrichment with that ability to go back and separate, okay, it's this stall, that stall, or this patient, that patient. If we have that scenario where it's the same patient that we're taking the 5 samples to clear it, or the 3 to 5 samples to clear it, can we pool pre-enrichment for that patient and just do a single enrichment step, a homogenization, single enrichment step, and then single PCR?
Everything is possible. I think everything is possible. I think if you're dealing with the same patient, it doesn't really matter. You could take 5 different fecal ball. You have to mix them together. So that's the beauty of mixing them, maybe adding some PBS in order to homogenize that and running one single analysis. It's interesting, when I was preparing this this presentation, I came across very nice data from Dr. Burgess on the amount of days that horses shed either post-clinical or these subclinical shedders. And I was actually puzzled. You know, we always think, you know, it's just a matter of a few days, but we know actually there's data out there that shows that horses with clinical salmonellosis can shed an average of 50 days after resolution of clinical disease. And if we're looking at these, you know, sporadic subclinical shedders that we pick in the hospital, we feel like, well, it's just going to be 1 or 2 days. But we know that the average, you know, is close to 30 days. There's a big variation there too. So I feel like we're sometimes rushing into running these 5 culture analysis in order to pull the horse out of isolation and give that relief to the client, saying, don't worry, you know, your horse isn't shedding. Maybe we should thinking about, you know, spacing it a little bit more. But I agree with you. We can take 5 fecal sample, homogenize if it's out of the same patient. If it's positive, it doesn't matter. We are back to square zero. It's like playing Monopoly. You're back to prison. You have to start fresh. However, if you pull from different animals, I would say do not pull biological sample. Pull the enrichment broth after 20 to 24 hours. That way, if you get a positive, you can come back. You don't have to go back, take the biological sample, spend 24 hours waiting for that sample to incubate, and then doing individual analysis.
Yeah, I think that's really valuable. I mean, I personally consider a trip to isolation a one-way trip. You're not coming back to the general population unless you really, really, really do something to impress me. And even if you tested 5 times negative for Salmonella, it'd be very hard to bring you back to the general population, in my opinion, as you say, because of that condensed window. Next slide, please, Eric. So, you know, this is a great question, right? So, and there's a couple of questions in the chat about this. You know, how many samples are needed? How often? Although PCR is sensitive, more sensitive, much more sensitive, we still have this fundamental issue that horses are intermittent shedders. And so we're not one and done, even if we had 100% sensitivity on our test. We can't be one and done because the biological sample varies from aliquot to aliquot. So I think the question is, when do we care about Salmonella? And it goes back to why we test for Salmonella in the first place. And so I think, there's three key points, and this will change a little bit, but one is, did they come in with it? We know when they test positive, there's always that question, oh, they got it in the hospital. And this goes back to the conversation we were having before about PCR being an indication for culture if positive. So did they come in with it? Do we have a test on admission that says, actually, this horse is Salmonella positive? If it goes to isolation, or if it's in the general population, we now know what that is, and we're going to manage it accordingly. Are they a risk to the hospital? Are they going home with it? So our horse that's in the clinic, that's tested positive, are they going to go home with it? And we touched on that just then. Are they a risk to the farm? Are they a risk to the owner? And then after they left, are they a risk to the environment? And we're going to come back to that next. Next slide, please. So when we think about culture, this is the fairly standard. We culture them at presentation. We take samples 12 to 24 hours, and we say they need at least 3 to 5 samples. But that's really dependent on that pre-test probability. If you have a horse that has a known that is positive for Salmonella, I would argue that you need at least 7 cultures to confidently call that horse negative based on that variable sensitivity and based on a pre-test probability of 1. When our pre-test probability is around 10% for our colic, then our 3 to 5 sample starts being much more relevant. And then we're going to worry about after they've left. Next slide, please. When we think about PCR, on presentation, it's not going to be just Salmonella that we're worried about. It's going to be Clostridia. It's going to be a range of other diseases depending on the age of the patient. So our PCR presentation is typically going to be multiplex. We're actually going to do a panel looking for a range of diseases. But we may want to continue to ask questions about that patient while it's in hospital. So we may have that idea, if this patient is Salmonella positive, that's going to change our treatment, whether it be leukopenic, whether it be a foal or something like that. So we may do daily testing on that foal. For our patients, our high-risk patients, or we want to know at discharge, we can do our pull-in, we can collect our daily sample as outlined, and we can do our in-house PCR. And to me, this is where this point-of-care PCR really becomes a game changer, because we can time it with confidence. We can say, we're planning to send that horse home tomorrow. We will plan towards that, and we will run the sample of our pooled aliquots. We'll run that tomorrow morning, and that'll give us a yes or no at discharge. What's the current status of this horse? Now, it may not be a binary yes or no, but it gives us an idea of risk. Yes, it's still positive, or it's been positive in the last 5 to 7 days, or it's negative. And so it may still shed, it may need further testing, but the risk is much lower. And then we're going to think about that PCR for environmental monitoring, and we're going to touch on that for a second. So I think that ability to time it and consistently know that when you have the sample, you can run the sample really becomes a game changer in terms of multiple sample testing, especially when we capture it together with the pooling. So hopefully that answered the 2 questions that were there. But it's not going to be one and done, whether it's culture or PCR. You're going to have to look multiple times because of the intermittent nature of the shedding of Salmonella in the horse.
I have 2 questions from the audience, and I think they're very, very relevant question. One is from Dr. Ferry on PCR negative, culture positive horses, and she has experienced a few of them, which, then leads to, the confidence in PCR. So what would you tell if somebody says, we say the same issue with, strep equi. I got a biological sample, it's PCR negative, I cultured it, and it's culture positive. Although I would caution everybody to say, well, not every culture is definitive, not any negative PCR is definitive. We got to know which PCR, what standards were used, and the same for the culture. But can you envision scenarios where, you end with a PCR negative, culture positive Salmonella, which then questions the validity of PCR?
Yeah, absolutely. And I think it's apples to apples, right? It depends on the sample. If you take one sample and you split it into 2 and you send it off and it gets cultured here and PCR there, you're not actually talking about the same sample anymore. As you said, this issue of the idea that the Salmonella is not homogeneously spread throughout the fecal ball is a very real scenario there. So the only way we could work through that and say, well, we really have, a specific concern or question there would be if we have the same sample post-enrichment tested negative PCR and positive on culture. So it goes to this issue that the nature of Salmonella, that it's not evenly spread, it's not homogeneous through the horse, it's not homogeneously shed, and even when it is shed, it's not homogeneous within a single fecal ball. And so that to me would be a very real scenario. The other is where we potentially have a false positive culture, where we have our definition being, say, black colonies, rather than actually going down to speciate that Salmonella. So I think both of those are very real possible scenarios. And that works both ways. We could have a positive PCR and a negative culture for the same reason, because it happened to be in the sample we took to the PCR had the Salmonella in it, and the other half, the fecal ball that went to culture, didn't.
I like that. I also would add on the PCR, it depends which quality controls are used. PCR is highly susceptible to inhibition, and it's not uncommon to see biological sample, fecal sample, that will give a negative result, but the housekeeping gene didn't show up either. So we know that there is inhibition, and the sample needs to be diluted further on. So it's not one of these questions that can be answered with a yes and no. We need, it's very individual. So, Darren, if you have any specific area, I'm always interested in troubleshooting these kind of scenarios, because I think these are the scenarios that will lead us further in our diagnostic. Please contact me if you have any issues, and then we can try to troubleshoot and figure out what is actually going on. And there's another question from Dr. Alano, and that pertains to kind of the accuracy of culture and PCR detection when you're trying to look at clinical versus subclinical patients. So in other words, all the data that we have generally, the number of samples that we collect and the overall detection rate and accuracy generally pertain to horses with clinical salmonellosis. So can we jump the same conclusion on a horse that is, subclinically infected?
I think it's a great question. I think it's a great example of, I don't think we have that data. We have so little data on subclinical shedders that I don't think we have the data to answer that question. I think in terms of the two things that really impact the capacity, the concentration of viable organisms, dilution in, a watery stool sample versus a solid stool sample, but then potentially having a higher concentration because you've got clinical disease. And looping back to, and it partly goes back to the question that Dr. Ferry asked, and the question I asked before about enrichment, I think it's very easy to underestimate that potential, that role of inhibitors, and that how important that is in potentially, and how inhibitors play a role. And I guess this is a question back to you. Do you think there's more inhibition in a diarrhea sample than there is in a formed fecal sample? Yeah, I don't know the answer to that, but you might.
I don't know either. It's interesting. There's a lot of geographic variation. We see, at least in the PCR lab, we see areas from certain geographic areas that we know we can account for a greater number of sample with inhibition, where the sample has to be diluted. Nucleic acid after extraction has to be diluted in order to get us reliable results. So it probably depends geography, maybe the microbiome plays a role. The consistency, water consistency, the amount of feces plays a role too. The dilution in salinite broth. So there's so many factors that play a role in this outcome. So that's a very complex, as you said, there's a complex question.
And it really loops back to it doesn't matter what we use, we can't be one and done. Mm-hmm. If we have a clinical suspicion, we have to ask the question more than once.
Would you know, in the amount of salmonella shed, is the data out there that support that, horses with clinical salmonellosis, enterocolitis, they will shed greater number of salmonella, hence it's going to be easier to detect salmonella. Maybe you're going to require, fewer sample than a subclinical shedder.
I don't think I've ever seen anything that's quantified what that means. what fecal shedding how you quantify fecal shedding. There might be something back in that early literature that did a lot of work. Salmonella was sort of interesting. I think it'd be interesting to I suspect we'd have to go and look at another species to get the answer to that question.
I agree with you. So when I finish with environmental testing, Eric, if I may ask you to move to the next question, to the next slide, please. So environmental testing, and I always think about testing the patient is probably the most accurate way, but we realize with Salmonella, small numbers, intermittent shedding, the alternative is really the environment, or testing the environment. We know that when it comes to Salmonella, it's probably the #1 pathogen when it comes to outbreak or epidemic disease in hospital. And Ben showed a great example where, all the biosecurity is in place, and despite that, these outbreaks still happen. And you start asking yourself, well, where do they come with? And I would say it's predictable. Contamination is predictable in any setting where you have a high density of high-risk horses. It's a matter of when. And so people that say we have no problem, I would say you may be lucky. There are geographic differences. There's also population differences, but I would say we need to assume that shedding and environmental contamination happens, especially in places where there is a commingling of healthy horses with enteric diseases, where, there's potential transmission. Where it generally starts is, so clinical shedder, my role, and I always tell that, it is easy to determine that a horse with diarrhea has salmonellosis, because that's a red flag. We will test that horse. We will put extra precaution barrier around them. We'll move them to isolation. My biggest worry is, what about the 99.9% of horses that are hospitalized that do not show enteric signs? How can I rule out that these horses aren't shedding? Because if shedding is present, what generally happens is Salmonella stays in the environment. Always depends on how well your cleaning and disinfection protocols are. And then slowly, that predictable contamination and spread, once it gets to the susceptible horse, you have the start of an outbreak. And for those who have experienced these outbreaks in these high-risk horses, it is detrimental. I mean, you got nosocomial infection, you have the risk of zoonotic diseases, you have, bad publicity, you have, loss of income. So these are really impactful outcome. Can you get to the last slide, please? So the question is, what do we test? And again, there is no right or wrong way to do this. It always depends if you're into routine surveillance or more targeted surveillance. On top of all the biosecurity protocol that we use, and potential, targeted screening of high-risk horses, it is also worthwhile screening the environment. These organisms have a tendency to stay in the environment. So what do you test? Where do you test? And I would say high-risk areas. Anywhere where you have high-risk patient. With high-risk patient, I'm looking at horses with enteric diseases. I don't try to discriminate much if the horse has diarrhea or just colic. We know that this is a population that will have a higher frequency of Salmonella shedding. So focusing on the environment, focusing on areas where there's a high movement, circulation. We're looking at, treatment room in this example, and definitely stalls or environment where horses with, the triad of clinical signs that are generally associated with Salmonella have been kept. I mean, that goes from the treatment room to, surgical suite to the stall. I mean, every time you see a horse with fever, enteric signs, and leukopenia, we got to think about Salmonella. If we can find it or not, independent of that, at least it gives you like a safety net. Think about these horses spend 99.9% in the stall, meaning if you can determine after you have cleaned and disinfected the stalls, since that's the whole key of environmental testing, we test a clean environment. We're not testing before cleaning, so removing all biological material and disinfecting. We test afterwards. And whatever is left, if we can find Salmonella, we know that there is contamination. We need to go back, clean, and disinfect again. And there's a variety of ways to do that. There's a little bit of studies out there again, using culture, there's no comparative study using PCR. There's different protocol. I always say, if you have a protocol that works for you, keep it. If you don't know what to use, look a little bit of the literature. You can use sponges that are moistened. You can use drag swab. We use drag swab in our hospital. You can use the electrostatic Swiffer wipes. Have a greater surface. Whatever you feel comfortable using, use it and build a level of comfort with them. The idea is to collect multiple sample, if you can, multiple sample from the walls, from the floor, from the drain. So the draining area is where all the water exits after you wash, clean, and disinfect. So that's really your areas where you can actually screen. And then if you have the luxury and you're a believer in pooling, that's to me a great way to actually use the pooling system. And you can say, hey, I'm taking 3 or 4 samples from a single individual stall. It doesn't really matter if you enrich them first, or you can pool the sample, enrich them, and then do a single analysis. Or you can pull samples from different stall. The problem is if you get a positive, you have to go back. So this different strategy, but I like the concept of environmental testing. It is elective. There's no emergency. You can plan it. If I look at our hospital, we collect approximately 50 to 60 individual environmental samples on a weekly basis. The samples are then individually enriched, and pools of 10 enriched samples are then processed for PCR. So we're going from 60 individual sample to 6 PCR analysis, considering that 98.2% of our sample will actually test negative. Now, if you get a positive, we're going to spend a little bit more money. We have to go back and test the 10 individual sample.
And there's a question there from Dr. White, and it's one of my questions. It's a ball of string question, but how many samples per stall would you take? I mean, the drain's the center point, but
yeah,
if you were
the drain is the center point, as you said. It probably depends a little bit on the material. So what is the stall made of? I mean, we're luxury to have stall mats that are sealed with concrete walls. So you can say, well, let's just focus on the drain and the floor. If you have an area, if you have an area of stall that has cracks and crevices and porous material, these are areas where you're more likely to find Salmonella. So it's not one answer fits them all, but I would say the more sample you collect, the more confident you will be on a negative result. I would say, if I have a choice, I would say walls, floor, and definitely the drain.
And do you have a preferred, as another question from Dr. Feary, do you have a preferred environmental sample type, like Swiffer, dry swab?
Yeah, I have little experience with the Swiffer. I think it's a great concept because of the surface. So think about it, the greater the surface, the more likely we will capture it. Definitely the Swiffer wipe will require, not necessarily, but generally people use them with a pre-enrichment step, which is an additional 20 to 24 hours in peptone, in buffer peptone water. So that's another option. We use the drag swabs in the hospital because we can use multiple drag swabs. We can put multiple drag swab in a bag of selenite broth, but the surface is relatively small. Since we started doing a lot of environmental monitor for independent studies, so respiratory pathogen, I've come to like the 3M sponges that are moistened. I like them. They have a good surface, and I like the fact that they are pre-moistened, meaning that there's more material that will stick to it. So if I had to choose one, I would say Swiffer wipes, sponges, and then last but not least, the drag swabs, so the little Q-tips swabs.
Excellent. And I think there's a couple more questions we can finish up quickly. Dr. Fury had a comment as well, that the degree of growth, like moderate heavy, may be an indicator of the shed-in. And you could make an argument for PCR too, you know, the counts. I think that's probably you'll be very careful, because it's going to assume that everything else is consistent, i.e. your enrichment time's consistent, your sample size is consistent and stuff like that. And then there's a question there from Dr. Schott, and I'll give it to you because I don't know the answer. Any comments as to why some Salmonella cerevars seem to be more pathogenic, independent of multi-drug resistance?
So individual server have been shown. I mean, if you look at the outbreak, they're associated with very specific server. It's probably the affinity to invade the tissue of susceptible hosts. But I also wonder if potentially is the amount that is shed and the infectious days that is associated with it. I have to speculate on that. I mean, there's virulence gene. Not every single Salmonella is similar to another one. Not every single server is similar. So there are, you know, pathogen specific differences, but each of these pathogen in the host may have a slightly different outcome in the amount of pathogen that is shed. So I would have to speculate here as to the answer. He always has these great answers. Thank you so much. You just made my day.
Excellent. I think in the interest of time, we're going to run out. Is there one more slide there, Eric? And so I think Eric might drop back on here, but I think just to make a comment, you know, we're very open to there's no one size fits all for biosecurity. And I think that's one of the things that gets very intimidating. People look at, you know, a certain institution and goes, well, I can't do that. Like, that's just way beyond my scope, way beyond my resources, way beyond my need, maybe, for what I need. But I think hopefully what we've discussed today is there's that real variation in what a biosecurity plan is going to vary from hospital to hospital, because it's risk-based, it's needs-based. But I would say that Dr. Pusterla and I are both really open to having those conversations with people and reach out to us and, you know, helping people build these things, because it is something that I think is very important to our patients. It's something that we have a passion for education-wise. And it's something that FHEA have been, you know, we really appreciate the opportunity that FHEA give us the platform to do this, because I think it's a really meaningful way to impact horse health. So with that, I'll sign off for the day and say thank you to everyone for attending, and I'll hand back over.
Yeah, thank you, Dr. Sykes. Thank you, Dr. Pusterla. I think hopefully the first of many of these discussions. You know, I think we're, you know, for us again, yeah, it's a pleasure to be able to help support the clinics, whether that's using our platform or not. And, you know, in the clinics that we work with, we always see it's, you know, where do I get started? It's a big endeavor to, you know, tackle biosecurity, and it seems like an expensive word, but I think, you know, we're trying to leverage, you know, our current users, use key opinion leaders, and really anyone else in the industry where we can pull these resources together and really just help, right? I think these are not fun situations to deal with, and sometimes you just need a little bit of help or a cheat sheet to get started. So, you know, happy to help and looking forward to the next session. All right, thank you, everybody.
Thanks, everybody.